introduce Maxine's son. She also of the Dana-Farber. We've heard about immunotherapy, biomarkers, and now she's going to talk about VEGF inhibitors and predictive biomarkers.
So hello everyone. Thank you to the organizers for inviting me and talk about this very important topic. So in the last 2 decades, the treatment management of RCC was first revolutionized by VEGF signaling pathway inhibitors. And today we have several VEGF targeted therapies that have been approved for first and subsequent lines of therapy. And in addition, they're being increasingly used in combination with IO agents. And so far, the results that have been reported show that the combination of VEGF plus IO has resulted in improved outcomes as well as better PFS compared to sunitinib monotherapy. So in spite of these very significant outcomes following VEGF-targeted therapies, the duration of the response, as well as the survival benefit, does vary considerably between patients, and so hence the importance of predictive biomarkers. A predictive biomarker is predictive if the treatment effect is different for the biomarker-positive patients compared to the biomarker-negative patients. And this is generally demonstrated via a statistical interaction term between the treatment effect and the biomarker status. There's a general tendency to confuse prognostic biomarkers and predictive biomarkers because the terminology is used interchangeably and really should not be the case because there are 2 different things. There's often a tendency to mistake a prognostic biomarker for a predictive one. We're all very familiar with the type A Kaplan-Meier curves, where it shows that for the same treatment benefit, patients, for example, with biomarker-positive status have a better survival than patients with biomarker-negative status. And this actually provides no predictive information, and it's really by only adding the curves of the control population that you can see that the biomarker provides the same information regardless of the treatment type. And so because the establishment of predictive biomarkers require a control population, it's a little bit more challenging to identify these. Not only do we need to show a statistical significance with interaction, but we also need to demonstrate clinical utility, and this is not always so straightforward. So as an example, in the CheckMate 214 trial, the benefit of nivolumab plus ipi compared to sunitinib was a little less impressive in patients with PD-L1 less than 1%. And so the recommendation in this case becomes less obvious, and other things in addition to the biomarker would need to be considered, such as, for example, treatment cost, toxicities, as well as comorbidities. So keeping that in mind, this is a table summarizing studies that have looked at biomarkers and tested them in the statistical interaction term, or at least considered the interaction between biomarker and treatment effect for VEGF inhibitors. Initially, there was a lot of interest looking at specific angiogenic factors and looking at treatment response. Ultimately, in the broader perspective, there was an interest to perform a more comprehensive analysis of biomarkers. So in this case, more deeper analysis of the multiple cytokines and angiogenic factors. And they used plasma specimens from a phase 2 study comparing sorafenib plus interferon versus sorafenib alone, which yielded no difference. And they created a biomarker index score comprised of 6 biomarkers to try to identify subgroups of patients that could benefit. And the interaction term was highly statistically significant. Turns out that patients with a low score were benefiting more from the addition of interferon, whereas patients with a higher score were more responsive to sorafenib. And so along the same lines, comparing atezo plus bev versus atezo alone versus sunitinib as part of the Emotion 150 trial, there was a comprehensive sort of exploratory transcriptomic analysis performed evaluating tumor angiogenesis, pre-existing immunity, as well as immunosuppressive myeloid inflammation, and see whether these played a role in terms of treatment response in trying to identify groups of patients that actually benefited from the combination. It turns out that using these biomarker subgroups, for example, in patients with low angiogenesis score, they were able to benefit from the addition of bevacizumab, as well as patients with a high T effector cell function and high myeloid inflammation. They were able to benefit from the addition of bevacizumab to atezo. It's also very important to acknowledge, given that we're increasingly adopting combination therapy, is that specific therapies will result in different molecular dynamic changes. And this was seen in the sorafenib plus interferon versus sorafenib comparison, where where the biomarkers modulate in a different fashion depending on the treatment type that was received. This is also seen in PBRM1 status. So this biomarker was implicated in predictive value in the RECORD-3 trial comparing sunitinib versus everolimus. But it didn't pan out in the atezo Emotion 150 trial, and then recently, as Tony has said, PBRM1 status has, again, potentially predictive value for nivolumab versus everolimus using CheckMate 025 specimens in the second-line setting. So clearly, these therapy-induced changes in biomarker expression levels has biological implications in terms of how it affects the tumor and response to treatment. Different patient population as well as study designs clearly also contribute to these fluctuating differences between studies and for the same biomarker. And probably going forward, it will be very important to dissect these nuances and go back to how this works out depending on lines of treatment, patient population, et cetera, to better understand as we increasingly adopt combination and sequencing. I'd like to close my part of the presentation by talking about the IMDC risk model, which was originally developed and validated for the purposes of prognostication. It turns out it also has predictive ability. So using the CheckMate 214 trial, they found that patients in the intermediate or poor risk subgroup had a higher benefit from nivolumab plus ipi compared to sunitinib. And the opposite was true in patients with in the favorable risk group, where they were more responsive to sunitinib. And based on these findings, there were changes in national guideline recommendations, because clearly it implies that patients in the favorable risk group have perhaps a different, distinct biology, which makes them less responsive to immunotherapy. So in conclusion, we must continue our search for robust predictive biomarkers. As we have shown and come to understand, is that metastatic RCC is a highly heterogeneous disease, and throughout the work of finding biomarkers and testing them, we've been able to somehow unravel a little bit of these complexities, but of course the work is not done. We should continue that. In the hopes of getting predictive biomarkers in routine clinical practice, candidate biomarkers should be validated as much as possible in different clinical settings in order to demonstrate clinical utility. Thank you.